Hi, everybody. Thank you so much for joining us tonight and welcome to our presentation on chronic low back pain and the ReActiv8 therapy. My name is Darylyn and I am a member of the ReActiv8 team. We're going to hear a physician presentation tonight from Dr. Darnule from Spine Team Texas. Then we're going to hear a patient story from one of our ReActiv8 patient ambassadors. Her name is Dena. And then throughout the presentation, if you want to put your questions into the Q&A feature or into the chat, we will answer all of your questions towards the end. And then we also are going to have an opportunity to get reminded how to make an appointment with Spine Team Texas if you want to get more information about ReActiv8 or be examined to find out if it is the right next move for you to deal with your chronic low back pain. I also wanted to mention that Sandra is here. Sandra is the ReActiv8 therapy manager for the Spine Team Texas geographic area. So if you do decide to go forward with pursuing ReActiv8, you will definitely encounter Sandra at some point. Sandra, do you want to say hi and wave?
Yeah, hi, I'm Sandra. I look forward to answering any and all questions that you all have. I'm super excited to be here with you tonight. I appreciate your time and I hope you enjoy learning more about ReActiv8 and how it can help with low back pain.
All right. So without further ado, I want to introduce Dr. Amit Darnule. He's an anesthesiologist and pain management physician at Spine Team Texas, and he is our host for this evening. Go ahead and take it away, Dr. Darnule.
Thank you, Darylyn. I also want to say thank you to everybody who took time out of their evening to join us. I love educating patients, particularly about new technologies. I've been in practice with Spine Team Texas for about 18 years now, almost. And it's been a great experience. It's a great team of physicians to work with, and we try to stay on the cutting edge of medicine, but making sure that whatever we do has a lot of strong evidence behind it. But throughout those 17 years, we've had our struggles because technology and tools advance at a different rate than we'd like them to. And so what we're going to talk about today is a tool that I think we've been waiting for a really long time, and I think it's going to help a lot of patients who previously didn't have many other options. You can go to the next slide. So we're mainly here to talk about chronic low back pain. It's one of the most common reasons people see their doctor or miss work or school, outside of things like infections that come throughout the year. And it's one of the most challenging types of pain that we deal with because there are so many different causes for low back pain. It can often be a struggle to figure out what's causing it, why it's happening, and how to treat it. And then often it doesn't respond to the typical treatments, particularly if it's been going on for quite a long time. So I know everybody on this call is likely here because they either have low back pain or they know somebody who's been struggling with low back pain. And more than just the pain itself, I think chronic low back pain also affects your day-to-day life. And so just to get a little warmed up using the chat box, I would like for the people logged in to think about how many days in a year you feel that your back pain has affected your work, your school, canceling vacations, changing the activities you had planned for the day because you had a flare up, all the different things where you had to make adjustments. And for many people with low back pain, their new normal is not doing things that they want to do. So it can be a high number, but I just want everyone to just chime in, and maybe I can ask the webinar team to add all those up. We have getting close to 60 plus people on this call and should climb as we go through. And if we add all that up, we'll get a good estimate of the kind of impact that chronic low back pain has, and it's often goes unrecognized. So let's go to the next slide here. Now, why back pain is a bit challenging. As I said, there's a lot of different causes for low back pain, and it would be very difficult to go through all the different types of low back pain, but we can subdivide them into two major categories. The neuropathic or the neurologic type of back pain, and then the mechanical type of back pain. So the neurologic type of back pain is what you may have heard of as sciatica. It's the burning, shooting nerve pain that goes down the leg to the foot. And it's primarily caused by the nerve itself or something happening to the nerve. So disc herniations, ruptured discs, pinching nerves, large joints with a lot of bone spurs pressing on a nerve. This is the kind of pain we're talking about. Now, for those patients, they will often do well if caught early with physical therapy, epidural steroid injections, and in some cases, back surgery. Back surgery actually has a really good track record with this type of back pain, and it makes logical sense. If you have something pressing on a nerve and you take that something away from the nerve, you relieve the pain on the nerve. So it makes sense. Now, some people, unfortunately, are left with chronic nerve back pain or nerve pain down the leg, even after they've had surgery, because there's just been too much damage done to the nerve. Either it's gone on too long or the thing that caused it was so severe that even after doing surgery to relieve the pressure, they have pain. And so in the 1960s, so we're going back quite a bit here, they invented a device called a spinal cord stimulator. And it has evolved throughout generations and works really well for this kind of pain, this nerve pain down the leg or back pain that is neurologic in origin. But not all back pain is neurologic in origin. And so that second category is the mechanical low back pain. This is the kind of pain that's due to physical structures in the spine, arthritis, disc bulges, fractures in the bone itself. And what we'll be talking about today is an often overlooked cause, which is weak core muscles or support muscles that are called the multifidus muscles. And then we bring up this other stimulator, the spinal cord stimulator, and I've been doing that now for over 20 years, just so that people understand that if you go out and you do research about low back pain and stimulators, you're more likely going to find a lot of old information about spinal cord stimulation because ReActiv8 is kind of a newer device that is treating a wholly different problem. And so if you have any preconceived notions or preconceived ideas about spinal stimulation, for example, I want you to just kind of put those aside because we're not talking about the same thing today. We're talking about something completely different. This stimulator we'll be talking about today is more of a restorative in nature. It's really going to go towards restoring strength in the low back. And it's a great alternative because surgery for this kind of pain is usually either not indicated or doesn't have as good a track record as it does for the other type of pain. And often these get mixed together. And so you hear a lot of data, oh, back surgery is not good, or this is not good, or that. It's because sometimes we're mixing these two different types of pain and not realizing that they're actually treated very differently. And there's a little x-ray there, and we'll go into more detail as we go into how it's done. But one thing you can just look at that to see is how differently the two little leads are placed. One is more central, and you can't tell, but it's much deeper. And the ReActiv8 stimulator is more towards this outside, and it's more superficial. And we'll talk about why that might lead to safety outcomes a little bit later. So let's go on to the next slide. So what's the prevalence of low back pain mechanical? Well, studies indicate that up to 2/3 of people with chronic low back pain actually suffer from a mechanical origin, not necessarily that nerve pathway that we talked about before. And treatment, you can go to the next slide. Treatment for this, because there's so many different structures in that spine, as I mentioned earlier, we have different treatments you'll see on here. So many of you may have already tried this or in the process of trying this, and that's fine. You should. It's time and rest and physical therapy, chiropractic, acupuncture, massage, different types of medications, ones that treat inflammation, ones that treat muscle spasms, and then things that treat just general pain overall. And then different types of injections where we put anti-inflammatory medications where we think the pain is coming from. And these can all be very effective, particularly in the early phases of back pain or when you have a particular flare-up, they're useful. But as back pain evolves over one's lifetime, some of these start to lose their effect. And while they may give temporary relief, we're often looking for something to fill this gap where you have much longer pain relief and addressing the underlying cause for pain. So if we're injecting near joints and we're injecting near nerves and we're even doing ablation sometimes, which although has a very good short-term record and has been the standard of care for a long time, we wonder sometimes, again, what can we do to make things better in the long run? And what are we missing if we've done all these things like physical therapy and medications and injections, and they still have back pain? What else could it be? We'll go to the next slide. Well, it could be your muscles, right? And people have heard this. And the first thing people think about is, yeah, my doctor told me about that and I already did physical therapy. But we're going to talk about a different set of muscles. There are a set of muscles called the multifidus muscles. They're a smaller set of muscles that run up and down the spine. And they're often overlooked as a potential cause for chronic low back pain. They're the key stabilizers that kind of keep your spine in alignment when the bigger muscles allow you to move and bend. So if you bend forward or you bend backwards or side to side, the bigger muscles are doing the actual rotation, but these smaller muscles are what keep the spine stable so that it can move through space properly. And these muscles are involuntary. Okay, so that means you're not thinking about doing it. You're not saying, I need to contract these muscles to do something. They're happening on their own. And that can also be a little bit challenging if you're trying to rehabilitate them because you don't really have any conscious control on them. And so injuries can disrupt and inhibit the natural function of these deep core muscles, and that can lead to overloading of the spine and lead to pain when you try to move. We'll go to the next slide. Okay, so why can these multifidus muscles cause so much pain? So let's talk about the healthy spine for a second. These muscles help keep alignment. As I just said, when you try to bend or move, it keeps everything in line. Now imagine if one of the set of muscles aren't firing properly and you try to bend or move. Now the spine isn't moving in a nice smooth fashion, but maybe in a more staccato or a little bit jagged fashion. And you may not even notice it. It's just happening at a microscopic level. This is what in the beginning doesn't really show much. You don't really feel much pain. You might feel just some soreness. But day after day, year after year, month after month, this is what can slowly build up to create damage over time that causes pain. And so I use this analogy. For example, imagine you get on an elevator at the ground floor and you want to go to the 10th floor. You press the number 10, the doors close, and the elevator goes up. What causes the elevator to go up? There's a cable. The cable grabs the elevator and pulls it up. That's the big motor fibers that allow you to move through space. But what we forget is that that elevator also has side rails that allow it to move up and down without banging into the side of the elevator shaft. And so as long as those rails are holding the elevator neutral like it's supposed to, then the mechanism of the motor pulls the elevator nice and smoothly straight up. Now, what happens if there's damage to one of those rails or more than one rail? Now you're moving through and there's a little bit of gyration, a little bit of shake. At the beginning, it's not going to cause much. Maybe it makes a funny noise. Maybe it's a little bit of a shaky ride that you feel. But if that doesn't go treated, it builds and builds and builds. Now it starts to affect that elevator to a point where either it can't move at all, or when it does, it really has to overwork the motor, or it starts to cause damage to some of those other elements in the elevator that are attaching it to the shaft in the first place. And so you get this sort of downstream effect from that. And that is what can happen when the spine is trying to move through space, but it's not really stable, it's shaky. And so when that becomes chronic, it's really tough for just medications to mask it and for physical therapy to just sort of rehabilitate it. But we definitely try. I mean, these are things we want to try, but what do we do in a situation where that's not working? We now have this option of restorative neurostimulation, where we can reestablish that natural function of those multifidus muscles to reduce pain, to create that stability to get things back on track. Okay, next slide. And as I mentioned in the last sort of analogy with the elevator, it can be a spiraling effect if nothing is done to treat it. You'll have an overload injury, it creates a problem that causes you to change how you do something, or maybe you stop doing that one thing, and that causes some more weakness. Now you have altered neuromuscular control when you try to move. So you stop doing that motion, you start doing some compensation, trying something different to get the same job done. And then that causes more muscle dysfunction and atrophy, and it just sort of cycles on. And on the right side of the screen, and we'll touch on this a little bit later when we go more into detail on how we identify patients, I just want to show you what those muscles look like if you were to look at them on an MRI. At the very top is what normal muscles would look like. And as you go down, you can see the increased severity of the muscle shrinkage, which shows up as less dark muscle tissue and more of this white, fatty, fibrous tissue. We'll go to the next slide. And so as that muscle gets weaker and weaker over a long period of time, this isn't something that happens in 1 month. This is something that happens over many years. Simple movements that you're so used to doing, that you've been doing your entire lifetime, suddenly become problematic. You can't bend down and pick something up. Difficulty getting out of a chair, walking, doing everyday tasks like brushing your teeth, vacuuming, and mowing the lawn. All these things you've done maybe 100 times before. Now suddenly, for no reason, you didn't really do anything different. You no longer are able to do those things. So that can be challenging. And by the way, I just want to point out, I don't know why the guy is doing the mowing and why the girl is doing the vacuuming. It doesn't have to be that way, but I'm just pointing that out. Just for a little joke in between. All right, let's go to the next slide. All right, so now I mentioned the elevator example just to kind of give you a frame of reference to how other things can go wrong when the muscles are weakened and you start to lose that stability. So most patients that have muscle weakness, they almost always have other things going on. I mean, it's rare that you'll see a nice normal MRI and look, all these muscles are atrophied. Usually by the time they come to us, they have both. They have the muscle atrophy, but they'll have 70%, for example, in this data, have grade 3 or higher disc degeneration. 70% have arthropathy or arthritis in their back. Large percentages have disc bulges and modic changes, which is where the end plate of the vertebral body starts to degenerate. Some of them have a minor slip. We're not going to talk about major slips. That's a separate scenario altogether, but minor slips because of that weakness. And some even have scoliosis. So it's not typically an isolated problem. Next slide. And so we then asked the question, what do we do? What have we been doing? Well, up until recently, we've had only palliative options. We try everything we can on that earlier list, and then we basically try to just focus on pain relief. And that includes medications, which can be effective, but they all come with downsides. And we didn't discuss that earlier, but anti-inflammatories are great, but you worry about your kidney and liver and stomach. Opioids can be helpful, but you worry about addiction and actually ramping up pain over the course of time. Muscle relaxants can be helpful, but they can make people sleepy and tired and don't always work in the long run. Injections can be helpful, but they're usually useful more for the inflammatory processes rather than for the everyday type of pain. And while, as I said earlier, ablations are fantastic, they've been working for a long time, are they really the best thing long term is one of the things we're starting to question. But again, that's what we had, that's what we did. If you dig into the literature, if you dig into some of the old things that were tried, spinal cord stimulation, phenomenal. It was that first stimulator I talked about. It's what was used sometimes for this problem, not because it was the actual best option, it was the only option available. But now that we have something else that's more specific for treating this mechanical type of back pain, I almost don't even think about the spinal stimulator as an option for that, unless it's that other type of nerve pain we talked about earlier. So what is ReActiv8? It's, again, this neurostimulative approach to improve function, to reactivate that muscle control, to restore that spine stability, and by default, over time, reduce pain by addressing the underlying cause. Next slide. So how do we do it? All right, well, it is an implantable therapy. So it's a therapy where, and the reason it has to be sort of implanted, I'll have patients ask, well, is it like that thing that you stick on your back and it causes vibration? Well, kind of in a sense. It has it's like a far distant fourth cousin in some degree. Yes, it stimulates muscle, but it stimulates the wrong muscle. So it's not getting deep enough to get to these multifidus muscles that we're talking about today. And to get to those, this fairly minimally invasive device was devised. Essentially, there are 2 leads that are placed just on the outer edge of the spine, kind of in that skeletal muscle junction, and then a small little battery implanted in either the upper buttocks or in what I call the back love handle in the back, where I can find a little spot of fat to hide it in, and we hide it in there. It takes about an hour or less to do, and there's 2 little small incisions. And once they heal, we really want people to start being active almost as soon as possible with this, because the whole idea about this device is function, function, function. Go to the next slide. What does the patient do after? So that's my part. Okay. So I do that part. And then the patient goes home and they heal. And then what they do is, what they do to get better is they use the device. I can't emphasize this enough. It doesn't work if you don't do it, right? If I give you a weight and say, lift this weight 10 times a day so you can build this muscle, and it just sits in the corner, it's not going to do anything, right? But fortunately, it doesn't require too much effort. What you need to commit to is about 30 minutes twice a day. So 30 minutes in the morning, 30 minutes in the evening, where you have to lay down, typically on your stomach in most cases to keep your spine neutral, but it can be on your side if that's more comfortable. And you simply turn the device on and let it do its thing. So it's fairly passive and very easy to use. And we'll have Dena, our guest here today, tell you a little about her experience about it. But that's all you're needing to do. It feels, because what we're doing is we're actually stimulating muscles, it should feel, I'll let Dena actually speak to this, but it feels like the muscles are just essentially contracting or twitching. And just like anything, it's going to start off very mild because you want to build strength and tolerance to it. And then you're going to want to up it, which you don't do. You work with someone like Sandra. When the time is right, she'll increase the strength, because as your body gets stronger, you want to make it stronger and stronger current for that. Next slide. So let's recap for a moment here before we get too deep into the data, which is our next section here. ReActiv8, again, what are we doing? Multifidus muscles are one of the major support muscles, stability muscles for the spine, okay? When you have chronic pain for a long time, these muscles can sometimes shut down. We can see this in basically how you move, and sometimes as well as the MRI findings. ReActiv8, a tool designed to reactivate those muscles, wake them up. And the goal here, again, is function. And I want to reiterate that it does not block pain signals the same way that the other stimulators' goals are to actually trigger pain relief. This is trying to increase strength, so stability. And then by default, as your body is getting stronger and more stable, it's able to handle more load, and therefore you're able to do more with less pain. So that's kind of the sequence. And we'll, again, talk about that in the next slide. But again, you have to use this device consistently. And, oh, there it is right there. So again, you're going to first feel you're going to feel functional improvements typically first. And then as you build strength, you'll build tolerance. And then over time, you'll start to see that now you can do more, and hey, it's just not hurting as much. And that's typically what the pattern that I've seen with most of the patients we've done so far. Okay, so let's go ahead on the next slide. Now let's talk about a little bit about the data for those of you who like numbers. How do we know that it actually works? Well, there's been more than 4,000 patients already implanted with the stimulator. There have been 5 clinical trials across a vast number of countries: Australia, United States, United Kingdom, and Europe. And those total patients in those studies, 567. Next slide. And in the first year, what they saw is that 52% of those patients reported near complete resolution of their pain symptoms. And that's just in the first year. And that, just to give you a reference, is compared to 6% for those that were just taking sort of the palliative measures we talked about earlier, like the alternative. So while you look at that, and some might say, well, that doesn't seem as high, I want that to be 100. Look at the gap between the alternative of 6% and the 52, and that's just in the first year. What the data shows is that, and I'm glad they did this, because a lot of things in pain will show one year data and it kind of stops. They follow these patients out all the way to 5 years, and you can see that the pain reduction and the functional improvements stayed. The top graph is pain reduction. The bottom graph is in metric. It's called a Zwischri Disability Index. So it just kind of measures functionality. The higher the number, the more disabled someone is. The lower the number, the better. And you can see we see almost 50% improvement in function. And function's important. I can't overestimate how long I've seen this in my career. We can go ahead to the next slide too. How, a focus on pain alone can sometimes miss the point. I always tell patients, I can give you so many drugs, which I wouldn't, but I could in theory, so that you would be pain-free, but you'd be asleep all day. That's not a life. What we want to find is the balance where we can improve your function so that you can have an improved quality of life while balancing against the downsides of whatever treatment we're looking at. And so when we look at patient satisfaction, how satisfied were patients who were in this study? You'll see that nearly 80% by 1 year and nearly 90% by 5 years were definitely satisfied with this treatment. 50% reduction in pain. You see improvements in function. You see improvements in also opioid use. So the data supports that while in some people, and remember that we're dealing with a very vast number of patients from maybe mild dysfunction to really severe dysfunction. I've seen patients with some, a decent amount of muscle to some where I almost can't see any muscle. So that's why you'll see some variations on how well some people will do. But I think progress is typically our focus. If we can improve quality of life, even 50% is a dramatic change for people. If we can get higher than that, perfect. Again, it depends on what we're starting with when we're working with it. Next slide. And then this slide kind of just goes to the safety aspects of this. As I said, it's an implanted device. There's going to be some risk associated with bleeding, infection, and things like that. But we mitigate that, making sure you're not on a blood thinner, make sure you don't have fever, temperature, that you do proper wound care, all those kind of things. And if done properly, it's very safe in that we're not going near any vital structures, not getting close to the spinal cord, anything like that. We're simply touching base on the edge of the spine at a particular level where we can stimulate the right set of nerves to stimulate these muscles. Go to the next slide. So as I said, it's a safe, effective, long-term treatment for mechanical low back pain with progressive improvement in function. And so this is where I would say that the ideal patient is the person with a long-term vision of what they kind of want to do in life from a functional point of view. They obviously want to get pain relief, but they're not shooting for, I need pain relief in the next week or in the next, like they want that. And of course, we'll work with other means to control those symptoms, but they're really looking for something that's going to make them better in 6 months, 12 months, 18 months. They want to see that, hey, I'm doing more with less pain, and I'm willing to put in the time and effort to do it. Next slide. So is it right for you? I kind of told you about the psychology of the patient that I'm talking about, but what is the physiologic part of it? Low back pain for at least a year. Again, more back pain than leg pain, although some leg pain is okay because some of it is referred. We call it referred when it goes from the back to the back of the leg, but it really rarely goes all the way down to the foot if it's really just from this source. They've tried the stuff on that slide earlier. They've tried maybe some of the injections. They've tried the physical therapy, chiropractic, acupuncture. They've tried a lot of the conservative treatment, just not getting better. They have an MRI that suggests that this muscular dysfunction is a likely cause because they've tried all those other things, didn't get better, and they have this atrophy, this shrinking of these muscles that should normally be quite strong. And more important, they don't have something else that should be treated first. So this isn't, again, a magic bullet for everything. If you have an SI joint problem, if you have pinched nerves, you have spinal stenosis, you have a slippage of vertebrae moving, this is not the treatment for that because your issue is more than just these muscles or stabilization issues. It's a little bit more of that nerve pain issue we talked about earlier. And then it's typically not indicated in people who've had previous instrumented spine fusion. In general, though, depending upon the level and, there can be some discussion with your physician if it's right for you. But typically, if there's a lot of hardware, it's just functionally you can't do it because there's hardware in the way. So it's not really for that type of thing. Next slide. This is just a repeat of the images we saw a little earlier, but now we're seeing them going kind of across the screen and hopefully a little bit bigger for you to see those differences. For you to sort of see what happens to those muscles over time. And I want to, at this point, I do want to just explain, because a lot of people, this is not your field, it's not what you do for a living, you're not looking at MRI images, that's our job. But because this is so underdiagnosed or underrepresented cause for back pain or unrealized cause for back pain, you actually, unless you're in the severe category, the radiologist may never even mention this in their report. And so you can't just look at, well, let me see what my MRI report says and see if I'm a candidate. Nope, they didn't say anything, I'm not. You really have to have somebody who's trained to look for it, to look at your MRI. So one of the next steps is, either talking to your physician, or if you're interested, as we said, have a specific consultation to look at the MRI and see, do you fit the pattern both from a physical point of view, from a experience of pain point of view, and the atrophy on the imaging as well. And so, it's nice to talk about the science and the data and functionality of it. But what I'm sure everybody wants to know is, what's it like to go through the process? And so I'll turn it over to Dena and Darylyn to talk to you a little bit about what the patient experience is like.
So I think that was a fantastic introduction. So I'm just going to go ahead and hand it over to Dina, and she's going to tell you her story about her chronic back pain journey and her experience with ReActiv8.
Thanks. Thank you, Darylyn. I am Dena Harrison. I am 78 years old. I am a grandmother of 18 and a great-grandmother of, I believe, 6, last time I counted. I couldn't even tell you when my pain started. It just started gradually, and I was diagnosed with arthritis, which I didn't think I was old enough to have arthritis, but I guess I was. And I'm going to read some of my notes, if that's okay with y'all, because I'm 78 years old. My back started hurting out of nowhere and progressively got worse. I've always lived a very active life. I used to love walking our dogs, sometimes even up to a few miles. I've never liked just sitting around, and I always enjoyed staying busy. After my pain became so bad, I did not feel like doing anything and spent most of my time laying flat on my back. A heating pad was the only way that I could get any comfort. I absolutely felt that I had lost my mojo. I could not ride in a car for very long, stand for any time at all, or even get comfortable sitting. My pain was definitely getting progressively worse. I found that if I added pressure with my hand to my lower back for some support, it helped a little. My mobility had started to be really affected. I have unsuccessfully attempted physical therapy in the past. The back pain was originally attributed to arthritis, and I was prescribed pain pills, opioids, that led to a dependency, so then I had to avoid pain pills after that. I was at the point where I was ready to try anything and felt like that it was worth it to take a risk. I felt desperate and really did not know if it would help. It seemed too good to be true. I trusted Dr. Darnule's explanation that my problem was with my muscles. I never even thought about it. I thought it was my nerves, I thought it was my discs, blah, blah, blah. And that ReActiv8 was the best option for the best result. I was told that it might take months before I could feel any results. Results were gradual, but I noticed that I wasn't hurting, and I could do things that I hadn't felt like doing for years. I finally feel now like my back can support me again. I'm able to work 12-hour shifts if necessary at my job with no back pain. It's not too bad for a 70-year-old great-grandma. I'm still doing 2 30-minute sessions every day. I have an alarm set on my phone to remind me to do the second one before midnight, because if not, it's the next day. So that helps me a lot. After a year, I had the implant done last October 24. After a year, I feel like I did when I was younger. Without ReActiv8, I could not be working at my job as a team lead for food service at my church. It requires me to be on my feet constantly. I love being able to be active again and feel unrestricted at work and help anyone with almost anything they need. My friends and family tell me that I'm back to being my normal, fun, crazy, spunky self again. I do definitely have a new lease on life. If someone is considering having ReActiv8, I would recommend reading up on it and to get all the information you can. It is, of course, a personal decision, but I would highly recommend it. I would have appreciated having someone to talk to me before I made my decision. This information from Dr. Darnule was amazing. I want to just share one thing. When I had my implant, and then I went back to have it, what was the word? wrote it out, activated. Sandra was my person, and we've become good friends now. And my husband came along, and I was laying on my side on the table, and my husband was sitting across the office, and she said, okay, if it's too strong, tell me, because we don't want it to be too strong at first when we first activate it. I said, okay. And she said, so how does it feel? I said, I don't feel anything. She said, yeah, okay, and then I'm going to up it. I don't feel anything. Are you sure you don't feel anything yet? I don't feel anything. Well, my husband and Sandra shared with me that my back was doing this. The muscle was being activated, but it wasn't going to my brain. I never felt a darn thing. I thought they were like kidding me. And that was a year ago. And now I can feel it. And it's worked. I feel like my brain is working better now. It's talking, my back is talking to my brain. I guess that's the best way. In layman's terms, I can say it. But it has been a life changer. It's like a miracle for me. And if anybody wants to talk to me, they can holler at me, because I would highly recommend it. It was a miracle. It was life changing for me.
Dena, about how long do you think it took once you started using the therapy before you noticed any improvement in being able to do things or in your pain?
It's so hard for me to say because it was so gradual. It was almost like it was so natural not to hurt as much and be able to do things that I just started doing things. And it was like almost like, oh my goodness, my back's not hurting like it was. It's something's different. And it just got gradually better. I could not, to be totally honest with you, I could not tell you how long. I would say maybe a month or two, but it wasn't. And that's what I appreciate about it so much. I tell people that when I try to explain, because they know everybody, all my friends, I tried every heating pad. I did the radio frequency ablations. I tried everything and nothing worked. And they noticed that I was better. They noticed that I was feeling better. And I explained to them about ReActiv8. And I've got pictures that shows what my back looks like with it implanted. And I show the pictures, and they're just amazed, how it works. And so they noticed it almost better than I noticed it, because I started being more myself, if that makes any sense at all. I wish I could tell you exactly, but I would say maybe a couple of months.
Before you got your ReActiv8, what was your daily life like compared to what you're able to do now?
My pain got so bad that I spent most of my time laying flat on my back with my heating pad. I would go to work and I wouldn't be able to do everything I was supposed to do. I had other people doing things for me. I took my heating pad to work with me, and I would do something and then I'd have to sit down, or I'd even go in the back and lay down with my heating pad. I, I could not function for more than an hour or two, and then I would have to get my heating pad, and that helped some, and then I would go home. And so back then I couldn't fluctuate. I didn't have fun. I couldn't play with my grandkids. I couldn't ride in the car for very long. I quit traveling because I couldn't sit in the car. I couldn't walk. Everything was wrong. And now I can do anything I want to do. So it's gone from being almost a disability to being that I feel fine again. It's amazing.
Are you still doing your sessions twice a day, or have you gone
I
down to less?
I am. The way I feel, like if it's not broke, don't fix it. It's like it's working. So I tell people that, okay, I'm working out. I've never worked out in my life. I'm working out. I exercise laying down on my side in a bed. That's the best way to exercise in the world. I mean, I brag about it. And it is. I lay down. I either get a book, or I turn on the TV and I lay on my side, and I have my timer where I can see 30 minutes. And sometimes, especially at night, I'll fall asleep doing it. I mean, it's not a bad thing. It doesn't hurt.
Yeah, what does it feel like?
It's so hard for me to say, to put into words. It feels maybe like a contraction. Like I said, I remember Sandra said one time, she said, it's kind of like when you work out. I go, I've never worked out in my life. I couldn't tell you what my muscle contracting feels like because I've never worked out. But my ReActiv8 is working out my back. So I guess that's what a muscle contracting must feel like. And it's cool. It's kind of magic.
Um, Dr. Darnule, do you have any questions that you'd like to ask Dena or anything you'd like her to cover before we address the questions that have been coming in?
Uh, no, I think I was actually just looking at some of the questions, and I think we can cover those next, unless you want to talk about the mentor program next.
Sure, really quick. So, Dina just mentioned it was the perfect segue that when she was considering getting the ReActiv8 device, she would have appreciated having someone to talk to about it. So, we have actually created a ReActiv8 patient mentor program. We understand that committing to a surgery and then to a therapy that you have to do twice a day, it's a really big decision and it's a big commitment. So we want anyone that's going into that decision to feel really confident that they are making the right decision for themselves and that they're really motivated to use the therapy. So we do offer the ability to sign up for the mentor program. It's through a great platform called Patient Partner, and it's 100% private. So you don't have to worry about, your information leaking or we don't even get to see the conversations that you have with your mentors, but you sign up, you take a little short survey, and then you get matched with somebody who is similar to you. And then you can ask them any questions that you have that you think would be helpful to discuss with somebody who has been in your situation and who's come through it and has the device and uses it every day. So we'll be sending out a little follow-up email after the presentation. You'll probably get it tomorrow, and it'll have some information in it. And this is one of the things that you will receive is the link to sign up for this program if you're interested. So that's the end of that little spiel. Let's go ahead and answer the questions. Dr. Darnule, do you want to kick it off?
Yeah, you'll go to the next slide real quick. And because I'll probably be referencing this a little bit, I was just kind of glancing through some of them, and some of them are general questions, which I think are easy to cover in this type of setting. I'll cover those, and then we'll kind of broadly discuss some of the more specific questions here. I think one of the questions was, is this covered by insurance? And the answer is generally yes. And why I say generally is because one thing I've learned in doing all this throughout the years is that rules some always change on us, and as we get to the end of the year, we'll be obviously waiting to see what the rules are come January. But in general, Medicare covers it, and I've had very limited problems getting even patients who have private insurance to cover it, mainly because it's if we can define the problem and prove it, we usually are able to cover it. But we definitely have to show effort on other things tried. MRI compatibility was another question. I think MRI compatibility is a big deal. Unfortunately, about almost 2 years ago, ReActiv8 was able to get the labeling, and sometimes that's just a process through going through the FDA. I mean, to fit all the testing that's required, but it is MRI compatible, or conditionally compatible is how we're supposed to say it. And what that means is that, like any implanted device, there's certain settings that you have to let the MRI center know, and just let them know. They'll look it up, and there'll be certain adjustments to the MRI machine that are typically made for them. There was a question about weight limits, and I would say that's a case by case because not all weight is distributed equally, and a lot of it is more about access and the ability to get the leads to where they need to go. There's also a question about feeling instability in their back when they move. Could this be the cause? The answer is yes. It's a little bit more complex. There's a lot of other things that could actually be instability in your back, and that's not what we want necessarily. But sometimes when there's a feeling of instability, but it's not something that's actually moving, it's sometimes those micro movements that's causing that. There are a few questions as well about, does this help with stenosis? What about if you have a stimulator and, if you had a prior fusion? And I think these are sort of those gray zone areas that I was mentioning earlier when we look to see, do we have a better cause for back pain or nerve pain for that matter than just the multifidus muscles? And remember, the spine, especially if something's more advanced, it's more than one thing that might be going on. And so sometimes we're going to combine different treatments for different causes. And so ReActiv8 can be a part of that treatment plan where it's helping address the axial weakness, the stability issues. But if there's something else going on that also needs to be treated, we're going to take care of that. And I think that's where, and I'll plug our own Google group here for that reason, but that's where a multidisciplinary group like ours, I think, is useful in this, because we can kind of take care of it if it's a surgical issue first. And then if there's something else left over going on, we can then address that in a non-surgical way. And so a lot of those are a case by case, kind of just based on what's going on at that time. As far as other things like, let's look here. I think in general, if you are interested in like the stimulator concept and you have tried a lot of different things and are not making progress, and it's predominantly the low back pain, this is something worth exploring. If you have a lot of those nerve pain shooting down the legs and whatnot, as I said, this might not necessarily be the one thing that you would need, but you'd have to have your imaging in your particular case evaluated in the office so that we can kind of see what's triggering your pain, where it starts, where it goes, and is there something else going on that should also be treated. So I'm just seeing a lot of specific questions on that part. I will say that there are a few things that if you are unstable, if your scoliosis prevents us from placing the leads properly in where we need to go, those are some of the things that are going to just make this a little bit harder. But I haven't seen a lot of those in general. Battery life was a question. Can someone speak to that?
Sure. So we're talking about the battery life of the actual IPG that goes inside of you and is implanted. So the battery does not need to be charged or regularly replaced. We have clinical data validating the battery life out to 5 years, but from an anecdotal perspective, a handful of patients who got ReActiv8 in the original clinical trials in Australia, like 9 or 10 years ago, only like a handful of those patients have needed their battery changed out. So we're seeing battery life of upwards of 10 years. So it's not something that you would need to worry about very often. The actual remote control is just regular batteries that you can change out when the charger dies. If you do need to have your battery changed out, you would just have a simple revision to switch out the IPG.
Right. Let me go through a few more of these if we have time.
Yeah.
Is one of my symptoms that my back is very painful when I stand up after a night of sleep? Possibly. I mean, movement, any kind of movement where you need to stabilize your back as you move through space can be a trigger. It's not the only one, but it can be. The downtime for the device for showering and swimming, those are a little bit different, but showering we typically allow after a few days because the water's running off of you. Swimming, we usually have people wait somewhere in the order of a few weeks, like sometimes 3-4 weeks, just to make sure that everything is water sealed. You don't have any wound issues, because we don't want to risk infection, because that just sets us back if something like that happens. But other things, like once you're healed, once the wound is healed, we actually want you moving around. In fact, people do physical therapy, and on top of that, play sports. The leads are designed to stay in place. We just need to give them time to heal so that they don't move. But we actually encourage people to be active once that happens. I believe the presentation will be available later. There was a question on that. We talked about that. Yes, correct. There's a question, is it, I have nerve-related pain? Kind of depends. If it's true nerve pain shooting down the leg, that's not what this is designed to treat. Um, but if it's nerve pain that's kind of in the back area, even though that's not what this is designed to treat, you should get evaluated because sometimes we think it is one thing and it turns out that it's actually something else. If you have a doctor at any one of our locations, there's a question about Rockwall, but in specific, but we have facilities all over the Metroplex, and we have physicians who have been educated in this. So if you're having this, if you fit it sort of from a clinical point of view, again, we have to go a little bit deeper digging and get you particularly evaluated for this, but you can ask your doctor about it, or if they are not as familiar with it, because as I said, it's kind of newer, and and you want to just talk to someone about it specifically to get evaluated, just let them know, and they will schedule an appointment with one of us, one of the people who do it. Or, as I said, you can request an appointment if you just want to specifically talk about this on our website, which is on the screen there. And we will have people call you and get you scheduled with the right people if you have specifically want to know about just ReActiv8, if it's for you.
I
If you
saw
again,
someone
go
I
ahead.
saw someone put into the chat, can I schedule a consultation now? Yes, you can. You can use the QR code on the screen, or you can go to spineteamtexas.com/about/contact us and fill out the form, and then the team over there will help you get scheduled.
Darylyn, can you show the device? Someone asked that how large it is.
Yeah, so I have to talk, otherwise it won't show me. But this is a dummy version of the IPG, and you can see it in my palm. I can hold up my lip balm next to it, so you can kind of get an idea of how large it is. It's about the size of a dental floss container, I would say, but it's a little bit thinner. So that is the size of the IPG.
CTs and X-ray question, yes, you can have those, no problem. If you have a pacemaker and a blood thinner, you're not excluded, but we would talk to your cardiologist and just make sure that everything's okay. And typically not something that interferes because it's not a very powerful uh, energy. It's really micro energy, really just to those muscles back there. So it's not typically spreading everywhere. Can it be seen? Will there be a bump? That really just depends on your body size and where we can hide it. We try to make it comfortable and hide it as much as possible. But I've always said to patients, the ideal patient or the patient who gets to this point is usually worried more about their function than how something may look. But I will tell you this, that it's not so necessarily noticeable just by looking unless unless you kind of show it where it is, or you have a very low body weight. And on that note, I was just reviewing some of the webinar chat, and I'm seeing a lot of 365 days over 27 years. So I think this group definitely is one that's in pain on a daily basis, and in general, that's the sign of something that's been chronic and been developing for a really long time, to a point where now there's minimal stability there. So definitely something we should explore with you if you feel like all the things we talked about in terms of activities sort of fit. In general, it looks like most of the we answered most of the questions that are general. I think there are a lot of specific ones, and I don't know if I can speak to them without knowing the entire case. But if you have any interest in specifically knowing, I think it's really a good idea to make an appointment so that we can kind of look specifically at that, because I don't want to say something is not, like you can't have it, because it is really based on how things look on the MRI, accessibility, and if it's appropriate, right? And so there aren't necessarily big lines in the sand, and it's up to you, it's up to the physician to see sometimes if someone's in a gray area, whether clinically it still looks like it would offer benefit, because we want to make sure it works. We just don't want to do something because we can do it. We're very adamant about making sure that we have a higher probability of success when we take a step towards doing something to help patients.
There's one other question about does the device stay implanted indefinitely? So the
Oh,
procedure is reversible, but most people, I think, elect to keep it because they're a little bit apprehensive to remove it and then risk their problem coming back and then needing to get it reimplanted. But that would ultimately be a personal decision if you felt like you felt great and never used it anymore and wanted to have it explanted, that would just be a personal decision.
it's a great question. I would say, yeah, the thing is, I just don't think we know. As I said, it's newer, so we don't have patients that necessarily have had it for 25 years, right? To say, do they need it or not? But it can be taken out if you want to have it taken out. But as we get older, I mean, usually people have this pain for many years. The chances of it returning are fairly high if you're not working out. Just like anything else, like if you lifted weights for a whole year and you got nice and strong, and then you just said, "Hey, I'm done. I'm just gonna stop working out." We all know you're going to lose some of the gains that you've had, and so the same thing can happen with any muscle, can happen with these. Whether it will cause the pain to come back, that I don't think we know. I don't think it's easy to say, but we're getting older day by day. So the probability is that weakness will kind of come for us in general. And I also tell patients, they'll notice, especially if you're in your 50s and 60s, your just general endurance and tolerance and muscle strength. It's called sarcopenia. You can also look this up, but this is just age-related muscle loss, period. We're talking about pain-related muscle loss, but even without that, we all lose muscle mass over time. And so in general, I have not had to take one out so far, but it can be. Let's say you just, hey, I need something, I need some other surgery, and it's in the way. Yes, it's reversible. And I think that's one of the big benefits of a treatment that is not doing anything structurally to alter your spine in an artificial way, right? There's no screws and rods. This is altering your spine in a muscular way, but not in an artificial way.
Dr. Darnule, which clinic are you located in?
I am at the South Lake Clinic. And I'd be happy to talk to you just if you want to know about it, even if it's a different position in our practice that you're wanting to follow up with and have it done. I'd be happy to even just evaluate you and talk to you about it and see if you're a candidate for it. And I do that for a lot of different things that we do, and just say, yeah, is this an option or not? And then it can be done by whoever's you feel comfortable with. But we also, I highly respect the skill set of all the physicians in our practice throughout the years, because I've seen them work with most of them for more than 10 years. So I see the outcomes, and I see their dedication in terms of making sure that they're picking the right patients and not just doing things because they can. They want to make sure it's the right thing to
Um, Dr. Darnule, could you go into a little bit what folks should expect from an appointment to get evaluated from ReActiv8?
Yes. So typically when you come in, if you're an existing patient, we'll have a lot of your information. If you're referring somebody else, or you're a new patient, or you're somebody new, you want to have all your intake stuff done ahead of time so we can spend most of the time talking about this and not the paperwork side of things. And then when you come in, we'll typically do a physical examination, see where you're hurting, see if it maps out correctly, look at everything you've tried so far, and then look at your imaging and kind of talk about both the history of what triggers your pain, as well as what does the MRI show, and see if we start to see alignment with the type of patient that does well with this. And then we talk about, again, what is the risk or your unique situation. If you have something that isn't, say, the standard looking spine, maybe you're scoliotic, maybe you have some other stuff going on. And we'll kind of talk about the pros and cons of both doing the ReActiv8 for that problem and what else may be going on in the spine that also needs to be addressed if we're wanting to get the best out.
All right.
Any other Any other general questions about the stimulator that I can answer?
I think if you have a really specific question, the best route to take is to speak to your physician about it because they're going to be able to give you a better answer based on your specific situation and your imaging and your history, your medical history. That it's tough, for Dr. Darnule to speak to.
Well, we're past our time here. And so hopefully if we want, we may keep this slide up for a little longer. If you can want to write down that URL or take a picture or with your phone or scan that QR code and make an appointment. Our team is aware that we are having this webinar tonight, so they will be trying to get in touch with you tomorrow at the earliest, or sometime at least before the end of the week, depending upon how many numbers they're going to try to call. And then they'll work with you in terms of finding the most convenient time and location for you to get a evaluation.
There is one more general question that popped in
Yes.
there. Someone asked, is there an upper age limit for ReActiv8?
No, I would say no in general. It isn't, age is a number, and I'm saying that as each year goes by myself. And so it's not so much the age number, it's just your ability to comply with what's required of you to get the benefit of the device, right? And I think in general, I've not met too many people who would not fit that.
The most senior person that I've anecdotally heard of receiving ReActiv8 was in their 90s.
Hmm.
All right.
I
Well,
would say I would say just to close that loop, it's really again not the age, it's really what are the other medical issues going on at the time. That plays a bigger role than I think a number itself.
all right then. Well, I think we are out of time and we're going to go ahead and wrap it up. Thank you so much to Dr. Darnule for joining us tonight and giving us all this great information. Thank you so much to Dena as well. And if you have any additional questions, feel free to go ahead and make an appointment with Spine Team Texas. They can get you all set, and there will be an email coming out very, very likely tomorrow that has links to lots of different information, and the recording will be included as well, so you can rewatch this if you want to.
Thank you. Thank you, Dr. Darnule. Hi, Dena. Thank you
Thank you,
for being
everyone.
here.
It was fun.
Thanks.
Thank you, Dena.
Thank everybody.
Have a
Hope
good
everybody
night.
has a great rest of your night.